Okay, so we're live, and today we have Dr. Shub. You and I known each other for a little while through the internet, really, and so it's been good to get to know you. And you have a very different perspective, or at least a different perspective, being a physician and also being over in the UK. So I think that'll make for a very interesting conversation. But before we dive in, can you spend a quick moment and just tell the audience a little bit about who you are and what you've been focused on?
Yeah, sure. Absolutely. Thanks for having me on, Brendan. It's such an honor, and a big shout to Josh for connecting the two of us as well.
Yeah.
So yeah, a little bit about me. I'm based out of the UK currently. I'm an emergency physician in senior training, so not entirely in attending yet, but somewhere along the way. I do that about 2 days in the week, and the rest of my week is spent working with clinician founders, where I help them take that journey from being a clinician to becoming a founder, and that's in my capacity as an executive coach. Beyond that, I'm really interested in innovation and improvement work. So I have some accreditations in quality improvement. And then I almost went into management consulting as an alternate career. So I really like management consulting frameworks as well. And I think all of that is coming together, especially in 2026, where I think there's a new version of healthcare coming to the fore. And I think clinicians are going to be at the front line. Their ideas are going to lead the way the new version of healthcare is formed. And we need them to be there. We need them to lead and make it right, because it's been broken for far too long now. So that's the mission I'm behind, and trying to help clinicians become founders and improve healthcare in that way.
Okay, so I definitely want to get into the whole clinicians as founders thing, but before we do,
Mm-hmm.
tell me more about where you see healthcare going in the next year. Like, how different is it going to be? Is that a European kind of change, or is that worldwide, or is that in the US?
Yeah, really interesting. So I've got a lot of colleagues. I grew up in India and I did medicine in India. So I've got a lot of colleagues across in India. I've got loads of friends in the US as well. And so chatting across the globe, I think the challenges are quite similar. I'm going to reference Dr. Zubin Damania here. He's got a podcast and other things. If anyone follows him, ZDog MD.
Oh, yeah. Yep.
He talks about healthcare 1.0, 2.0, and 3.0. And he talks about how healthcare used to be this thing where the doctor was the focus of the community, and everyone would kind of go to this one doctor for all their needs and all their health needs, and there'd be a really personal one-on-one connection. That then kind of got industrialized with the Industrial Revolution, and essentially the power has slowly been taken away from that individual. And it's been put into almost like a factory setting where patients flow through the hospital in different segments and different bits, and different doctors, clinicians, nurses come in and do their part. And it's meant to be a really efficient system, really high revenue, high profit generating system, and essentially been industrialized. And that's been happening over the last 20 to 30 years. And we're currently at sort of the tipping point of where it's all breaking down right now. Patients aren't happy, clinicians aren't happy, we're not getting the outcomes we want, businesses are losing money, and insurance is just, don't even get me started on that. I'm really lucky that we don't have insurance in the UK and Europe, and I'm happy to talk about that as well. But I think this is what's bringing forth the next version of healthcare, what he calls healthcare 3.0. And I think it's really about putting patients at the center of care again, giving the control back to them, because we've stripped away the ability for clinicians to lead the system, but the responsibility still lies with them. And any clinician who's listening to this will tell you that no matter what goes wrong in the system, we are captain of the ship, and the buck stops with us. And we're the ones that end up in court. We're the ones that pay the legal fees. We're the ones dealing with all the challenges and the complaints. But we don't really have the ability to change it as much as we used to, because of the behemoth of the industrialization.
Okay.
Anyway, lots in there.
All right.
I'll
Okay.
let you take it from there.
All right. No, I'm fascinated by this, because as much as I'd like to see that happen, it requires the consumer to be pretty knowledgeable about healthcare. And I'm sure that AI will help with that a great deal. And some of the apps that are kind of patient and consumer facing will certainly help accelerate that. But at the same time, I just went through a procedure, or in the process of going through a procedure, and and I consider myself pretty educated in terms of navigating healthcare, and it's tough to do. You really have to know what you're doing. And in fact, as a quick sales tip, if you're, I probably mentioned this before, but if you're a salesperson or you're a founder, like knowing And being aware of that that process as you go through it is incredibly valuable experience in your in your selling, because when you're in the physician's office, when you're going to the clinic, when you're going through the hospital, pay attention to those details, because those are the sorts of things that you can work back into your story and the examples and inform kind of your sales strategy. So anyway, that's kind of a bit of an aside, but so with that in mind, from the physician standpoint, because you're a physician, you're training physicians and so forth, what is it that makes a clinician more capable of being a founder, and what is it about it that gets in their way? What are the disadvantages of being a clinician, for example?
Yeah, really, really good question, Brendan. Thanks. I think let's start with the disadvantages first. So I think as clinicians, we work in a situation and we're trained in a way that mistakes are almost unacceptable, right? We have the concept of never events, if you've ever come across that. I don't know if
Right.
it exists in the US,
Yep.
but things that just should never happen. And then there's checklists and balances to make sure that the right care is delivered to the right person. So we were talking about what makes clinicians, the disadvantages of being a clinician as a founder. And I was saying how the system's really geared towards minimizing errors. And we do that through our training as well. And a lot of what many of us, like, I'll give you an example of myself. Like growing up, when I was thinking about the careers and things I could do, business was one of those things that I just didn't want to do. And I kind of was running away from money, running away from, having to deal with people. And I think a lot of clinicians are self-selecting in that sense. We want to be good at our craft. We want to be good at the bit that we can have most control over. And that's a huge reason of why we went into medicine in the first place. Now, those exact reasons are why you don't do so well as a founder, because being a founder or running a business is so much about managing the uncertainty. And you know this, Brendan, you probably
Yeah.
work with loads of people who
Yeah.
struggle with
Yeah.
that uncertainty element and try to make decisions without getting the information and data that they need to make those decisions. And so that's the big challenge. But at the same time, we are so obsessed with patient outcomes and patient care, and just the lens with which we look at the patient journey is very different from the way a business owner or somebody else would look at it. And I think a good clinician in reality is a good advocate for their patient as well. And I think that's the reason why we need to be founders, because we're not just the voice of the healthcare system and the science behind the practice, but we're also ideally, in the best case scenario, the voice of the patients. And leading from that space is really, really powerful and very
Yeah.
important.
Yeah, yeah, but you're the level of training you have, the kind of rigor, that you're kind of forced to employ in all your decision making. I have some experience dealing, with founder doctors as my boss, and there's definitely a bit of a mindset. What sorts of mistakes did clinicians typically what mistakes are they likely to make? Like, what are the things that get in the way that we should be looking for? And this is useful for me because a fair amount of my selling and working with companies is, physicians are in decision-making positions, or they have a chance to influence, and they also have a chance. They typically there's a high degree of like consensus building and collaboration. They tend not to, because of the hospital setting, the healthcare setting, there's a lot of collaboration and, decision by committee. So how do they typically, how are they impaired, or what are their blind spots?
Yeah, 100%. I think decision by consensus is a very common thing. I mean, we literally create mini MDTs or multidisciplinary teams to come to a common consensus because we deal with those ambiguous situations and we rely on people's opinions. And as a clinician, 5, 10, 15, 20 years into your practice, every day, multiple times a day, you're making decisions and you're making management plans and you're recommending solutions for problems, right? And so we get so into that even as a founder, we're so focused on what the solution is. And, tell me if this is right or wrong, Brendan, but being a founder, running a business, doing your sales is hardly ever about the solution. It's so much more about the problem. Like, how well do you understand the problem? How well can you extract that from the people you're trying to serve? We forget that we've spent such a long time training on extracting that problem that we can do it in seconds. When a patient comes into a resus room or an emergency room, it's literally seconds within which we have to figure out what's going on and decide on what to do about it, because
Yeah.
life's at stake. But that kind of happens so much in the background that clinicians immediately just jump to solutions and jump to, hey, this is how we're going to do it. And we're long-term thinkers, we're planners, and that's exactly what gets in our way. And I'll let you elaborate on how that might get on our way,
All
actually.
right. So this is fascinating to me because I think you're an ER doc, right?
Mhm.
So I have a preconceived notions about physicians, and it depends on what kind of doc they are, right? What kind of doctor they are. So ER docs are, in fact, I'm right now coaching at least two other ER docs.
Mhm.
And the thing about ER docs is they're kind of utility players. They have to be able to do everything, right? And there's a little bit of a God complex, right? Because everything happens quickly. It's gunshots and trauma and overdoses and whatever. And there's also the tedious stuff, but the more tedious stuff. But ER docs they have to be able to play every position. Whereas an orthopedic surgeon doesn't have to do that, right? Typically, my dad's was an orthopedic surgeon. Or if you're an oncologist, nobody does anything in oncology in a matter of seconds. So I guess to some degree, I'm curious, like the wiring, like if you had someone come in and say, I want to be a founder, like what kind of, I would think an ER doc would be a better person to have than, say, an oncologist.
That's really interesting. So currently the people I work with, I'd say I've got 4 surgeons, various specialties. I've got 3 or 4 non-surgeons, so like medical side of things.
Yeah.
And I've
Yeah.
got another ER doctor as well. And I think the surgeons are definitely more decisive or wanting to be decisive to move forward, and they're willing to take action. I think the thing with ER docs is it's funny, right? When we're managing risk and when we're thinking about risk, the first thing to do is eliminate it, right? If there's a risk that you can avoid or just not have in the room, you don't want that.
Right.
And so, when you look at a business or an opportunity to found something, there are inherent risks that you just immediately want to say no to. Like, let's not even bring that on board. And you try and thread the needle in a way that you might get through it without taking on risks. And if
Yeah.
something goes wrong, fine, we'll manage it. And I think that's often the ER mindset, which again isn't that helpful. And I think it's probably more the surgeons that I find willing to, they go through such a rigorous training process, and just the culture in surgical departments is that they're very willing to quickly take on feedback and say, okay, what do we do next? What do we do
Yeah.
next? Just
Yeah.
move ahead.
Yeah.
It definitely plays into what they're like as a founder.
Yeah. Well, I would, at the risk of belaboring this, I would think that ER docs would be kind of more willing to take risks because there is the ability to, you don't have to do things perfectly in the ER room, right? What you have to do is basically you want to stabilize someone, and then like they've got trauma, they've got broken leg, right? Whatever, or collapsed lung. And then what you want to do is stabilize them, and then you dump it off to somebody else, right? The pulmonologist or the orthopedic surgeon to fix the thing. And what you want to, so you're really kind of a medic, right? And so you have to be good at everything, but you don't have to be, I mean, you might be a perfectionist, but you don't have to be perfect. And I would think that to be a founder, like that would be a skill set that would be,
Yeah.
yeah.
I think there's strengths in each of them. So I'll tell you what I do with my clients is I do a couple of assessments. One of them is a Gallup Strengths assessment, which gives us a validated idea of what is their unique abilities, what sets them apart, and what's helped them in their career so far, and what's going to help them as a founder. And another one's a LINC Personality Profiler. Now,
Yep.
this one's really interesting because it gives you your motivations, and one of them is your risk profile as well. So for me, funny enough, I have like an abnormally low risk profile. I'm very willing to just do things and see how
Yeah.
it goes.
Yeah.
Very much emergency physician of me, and I think a lot of my colleagues might be that way as well. But equally, there may be some people who aren't, and that might be part of the reason why they're not staying in the same game that everyone else is playing, and they want to do things differently.
Yeah.
So yeah.
Well, so yeah, so, all right. That just because I do know clinicians that like orthopedic surgeons. I've spent a lot of time with orthopedic surgeons, and they'll go and they'll invent something, a specific device or a fastener or what have you, and then that's very niche specific to their area, and then it becomes how do they how do they act as a founder to advance that idea? But it's yeah, I don't I it that fascinates me.
Yeah, you're absolutely right. And I think a lot of people mistake the idea of innovation or inventing something or, opening a website as being a founder. Kind of alluding to what we were talking about before we started recording is, being a founder is really about implementing the change that results from your product or
Yeah,
from the innovation that you've
yeah,
kind of thought about.
yeah,
Often people will go so deep into their research into creating this fantastic product, and then they think that their job is done, and then they want to call themselves a founder. But there's so much more to that. It's the human journey beyond that. It's about the connection. It's about the difficult bits that we didn't want to do before getting into medicine all over
right,
again.
yeah,
But now we're like, hey, actually, there's potential. We've started seeing the light at the end of the tunnel. Where like, this could be like a multi-million-dollar company, and there's just a constant tension between the two spaces and the identity of a clinician, and what does it take to really be a successful founder? And yeah, it's a tough one.
yeah. Well, so in my travels, I run into a lot of physicians that are physicians part time, and they do something else. In fact, it's probably fair to say that that happens more. That's more likely than it is in any other capacity in healthcare, and probably is that there's a real tolerance inside the organization to allow docs to do something else and be docs, be doctors and provide and be physicians part of the time. I'm dealing with 3 or 4 of those right now that are physicians now, but they're clinicians in some capacity, but the hospital or the health plan allows them to do something else. What does that look like from your perspective as a physician or as a clinic? How does that play out?
I think it's quite simple. I mean, your relationship with the patient is almost always one on one. And there comes a point where we have this itch to scale beyond that. Like, if you look at the number of people you could impact in your lifetime as a doctor, just one patient at a time, it's really, really slow. And, when it comes to being a founder, when it comes to scaling that, there's so many more lives that you can impact. Even if you just simply take your mission onto a YouTube channel, for example, you could change thousands, if not millions of lives at a time, right? And if that's really what you're behind, that if that's what you're after, then why wouldn't you do that? And I think there comes a time in all our careers where we sort of start to have that itch. There's really in the people that I've spoken to now, like hundreds of clinicians looking beyond just their clinical work. There's three things that keep coming up. One is that scalable impact. The second one is they want better income, but better in the sense of it being sustainable. They no longer want to trade their time for money. And the third is they want autonomy back. They want control over what they can say yes to and no to, and not always be tied to a location and have some manager tell them that, hey, you got to come into work or you're not going to get paid, or your study leave needs approving by 3 people and 6 forms. And yeah, so those are the three things that they're commonly after, really.
Yeah.
And I
Okay.
think we all want to build careers that head that way. And I think, going back to what we were talking about in healthcare 1.0, that used to be the dream. That used to be what being a doctor always meant. We'd always do more than just the clinical work. So I think we're just heading back and refinding that balance again.
Okay, that makes sense. So now, going kind of more stepping back a little bit and kind of talking about various health systems. You're based in the UK. I would argue simply that the it's NHS, right, and the other systems in Europe are pretty in terms of their business models, if you will, versus the U.S. Those of us in the U.S. tend to look at the U.S. healthcare system and don't look past our borders. And how different would you say being in the UK is from? I mean, how translatable is what you do on the clinical side? I'm sure it's more translatable than uh, than uh, than than on the administrative side. So, kind of share your perspective.
Yeah, I think it's vastly different as an experience from the perspective of a clinician or as a patient. I think, even the fact that you use the word business model, it suddenly felt like, oh, the NHS has a business model. Oh yeah, it actually does have a business model.
Yeah,
But the truth is, you don't see it, you don't feel it, because as a
right,
clinician, I don't know the cost of any procedure. I don't know the cost of an IV cannula or a drip or a
right,
bed space, right?
right.
I mean, I know that now because I've ventured to the other side, but as a clinician, I don't. And
Right.
neither does my patient. The patient comes in, sees a clinician, gets whatever treatment they need. They get a CT scan or an MRI or a surgery or, a month-long stay in the intensive care unit. And when they're better, they're discharged and they just walk out. That's all it is. There's no billing process. And so that it's mind blowing. Like, even from me having seen the Indian healthcare system, it just doesn't work this way. Like, even if you've got government grants or insurances, there's always a process of billing, and you go and get that cleared through your insurer before or after, whatever, pre-auth or not. And this is just absolutely wildly different. And so that means that the way the hospital functions and makes money is also very different. So, and I don't think anybody has the real answer to this. My understanding is that the hospitals project usage of the next year based on the previous year. And based on that, they're allocated a budget. And once they spend the budget, they can claim it back from the government. And
Yep.
so everything else kind of is downstream of that. So within each division, department of the hospital as well, you've got budgets, and that allocation is very arbitrary, and it may not actually be truly representative of what's on the ground, which is what leads to very, very long sales cycles, because there's supposed to be money, but ends up never being enough. And
Right.
that cycle just kind of continues over and over and over. And to kind of get in there in a space where you can have some independence is like, I don't know, finding a needle in a haystack, or what it can feel like to many founders. It's a challenging space. It's getting better. They're developing more pathways and standardization around it, and obviously there's procurement because hospitals have to function in some way. So yeah, it really is about who you know and what time you're approaching them at.
So if you're doing something in that space and you're focused on the UK, Europe, and so forth, the solutions are almost invariably clinical or patient facing in some way, I would think, as opposed to, I mean, there's probably no such thing, I'm exaggerating a little bit, as a revenue cycle management opportunity inside, right? Or, you know, or, or claims analysis, or, because those processes almost don't exist in the UK, correct?
Yeah, that's interesting. So let's think about that for a second. So we do have business intelligence within the hospital that looks at a lot of data. We do have, you must be familiar with Epic as
Oh,
like
yep.
our huge EHR. So we've got that here as well. And you've got coding systems, you've got huge teams that kind of code on the back end as well, because, say I've prescribed paracetamol for somebody. And they receive that every day for 10 days. That is part of their records, and then eventually it does get reflected. So I suppose there is some scope, but as a clinician, I have no idea where that exists. And it's not something that I would think about, and I don't think other clinician founders would think about. I mean, the closest is I've got a founder working on admin workload efficiency, but more sort of front end patient facing reception and ease of finding guidelines and repositories rather than revenue cycle. But yeah, that's an interesting one. I hadn't thought
Yeah.
about that.
Yeah, it's if it's care delivery, I'm sure there's, because there's Epic, there is a kind of electronic medical record that's generated, but the value of that is in tracking and doing analysis on outcomes and probably expenses, utilization at some level, but you don't have call centers, for example, right? There's no, like, how often does a patient call in and say, I'm disputing this particular claim, or I need to get authorization or whatever? You don't have
Doesn't
that.
exist.
Right. So those sorts of things just don't have. And therein lies why your healthcare is 8 or 9% of GDP and ours is closing in on 18%.
Yeah. Yeah. I mean, I'll caveat that with a growing private sector of
Yes.
healthcare within
Yeah.
within the UK.
Yeah.
And I think it's going to really be massive in the coming decade or so. And there's obviously opportunities for all of this to be translated and brought across to the UK where it probably didn't exist before. But
Yeah.
yeah,
Yeah.
majority is still the NHS.
So are you finding yourself with your customers, with the people that you're coaching and consulting with, are you trying to push them to consider the US market?
Not particularly. I think the idea, I sort of work with them around pilot, pre-pilot stage. And I think to start off in an environment that you're familiar with, the network that you already have existing is the best option to start off with. There's no reason why that couldn't then later go across. I suppose big picture is that we're kind of in that space where I have one client who is building his own massive ecosystem. for all the way from clinic to pharmaceuticals to delivery. It's a work in progress, but pretty much everyone else is in a place where they're going to have to sell into the NHS for their business to be viable. I suppose if you can do that, it's a different challenge, but it's still possible to do that across into the US.
Yeah. Yeah. But invariably, if you're doing that, if you're selling into the UK first, it's gonna be a clinically focused or patient focused sort of a solution, I would think, as opposed like,
Yeah, usually is.
yeah,
Usually, yeah.
yeah. That's fascinating. And conversely, if you were to coach someone in the US on and it's revenue cycle management, it would have no applicability over in the it seems unlikely that it would have applicability over in the UK or in
Yeah, at least not to the NHS, but perhaps to one of the private providers.
yes, yeah. Is and you're seeing that blow up now?
Yeah, there's already a couple of big players nationally, and then local physician-led centers are also growing massively.
Yes.
So, yeah,
Yeah.
huge
Yeah.
opportunity.
Yeah. And that is that concierge medicine more where they're physicians that are going private pay and Cigna's been in that world in the UK or in Europe for quite a while actually. So
Yeah, so I think physicians going private's been around for quite a while, and I
yeah,
think so the big player now really is Bupa, and Bupa's come in with insurance, but it's really more like annual membership for access to faster services.
yeah,
And the waiting list for elective procedures is just so high, just
yeah,
so long that people turn to private hospitals for that. So
yeah,
there's large chain of private hospitals. They're called Spire. They're pretty much in every town.
yeah.
You can get your surgeries done there instead of waiting for 3 years for the NHS to do it. Yeah, so just growing opportunities.
Okay. Oh, very good. Well, all right. So as we wrap up here, Shub, like any last comments or how do people get in touch with you?
Yeah, so I think what I'd say is that sales is scary and sales is something that we don't want to do, but I think the reality is as doctors we do it well and we do it every day with every patient. Like every treatment is a sales conversation. And if you can kind of think of it that way, it's not that difficult, but I think it needs a different mindset, it needs a different way of looking at things, and it means that you're going to feel uncertain and unsure, but that's why people like you, Brendan, are out there helping us deal with the sales cycles.
Well, I think you're at some level you're at an advantage because the way I think about it is the way I think physicians often think about it is not as a sale, but as a consult. It's an opportunity for you to present options, and you're at an advantage because you're there and you can usually help them. So you're in a position where you can help them. In a lot of situations, you're trying to evaluate whether in sales situations you're trying to evaluate whether or not you can help them. But one of the things you want to be able to do is provide options. Here's what we can do, or here's how we can, I can help you, or we can help you, and that sort of thing. And physicians are actually, I would think, in an ideal situations because you're trained to think in terms of how you can help them, and in some cases you can't, right? Right? If you're an ER doc, right, you're going to help them up to a certain point, but then you want to you're not the person that's going to replace their ACL, right, or
Absolutely.
reattach their ACL. You're gonna make them feel better, take the pain away, reassure them that everything is okay, and then you're gonna point them off to some orthopedic surgeon and have them kind of finish things up, right?
Absolutely. Yeah. As I keep saying, ABC, always be consenting. That's that's the approach to take. And yeah, I guess if anybody wants to reach out to me, I'm on LinkedIn. So Shubhendu Kulshreshtha. Hopefully the link will be somewhere in the
Yep,
description.
will be
Or if you want to find me on Instagram, I'm at Shub Says Impact. You can find me there as well. So yeah,
very good.
you can have a chat with anyone.
Well, Shub, it's pleasure as always a pleasure to chat with you about this stuff, and wish you the best. And by all means, if you're particularly a physician that's looking to do something else. Additionally, Job's the person to talk to. So thanks, Job. Great talking
Thanks
to
so
you.
much, Brendan. Pleasure to be here. Lovely chat as always. See you at the next one.